time, I introduced sickle cell disease. You know, its pathogenesis, some of its characteristics, some of the common illnesses that come up with it. So what do we do about sickle cell disease? How do we diagnose it? How do we treat it? So diagnosis today is done by genetic testing. You know, we can test the DNA for that one point mutation that causes sickle cell disease. So we can not only identify sickle cell disease, you have two defective genes, but we can also identify sickle cell trait, which is informative to parents. You know, sometimes it's an ethical two-edged sword. You know, do you want to find out if you're a carrier of something? But it can help you in decision-making about, you know, or at least being aware that there's a risk for disease in an offspring. We're always looking for better treatments for sickle cell disease, but like so many other genetic disorders, we can't fix the root problem. You know, this gene is present in every red blood cell, is present in every cell in the body, so we can't fix it. So instead, we have to deal with basically symptomatic treatment and trying to prevent what comes later. In some patients, a medication called Hydroxyurea, which is actually used to treat gout as well, helps to reduce the frequency of crises and has worked to prolong the lifespan. But it doesn't work in everybody. So the only way to know if it works is to try it. So the vast majority of sickle cell patients have had a trial on Hydroxyurea, and people who responded then stay on it the rest of their lives. So because the sickling, or that change in the shape of the red blood cell, the trigger for that is deoxygenation. So when that red blood cell enters an area where the oxygen content is low, that's what triggers it to change its shape. So it sort of goes without saying that if we can avoid those low oxygen levels, we should be able to avoid some of the symptoms or a sickle cell crisis where you get a blood clot as a result. Other things that trigger sickle cell crises are dehydration, acidosis, infection, really anything that stresses or challenges the body. So like in kids, very often they'll get a cold or an upper respiratory tract infection or some little illness, and that'll trigger a sickle cell crisis because it lowers oxygen levels, increases acid levels, and can trigger a problem there. So we try to avoid those things. These patients become asplenic. You know, their spleens die off. Basically, they're infarcted out of existence over and over again from these repetitive small infarcts. So we give them not only normal immunizations, but we also give them the immunizations for people who don't have a spleen, you know, like the pneumococcal vaccine, for example. And then if there's any risk of blood-borne exposure, like in dental work, for example, we'll give them prophylactic antibiotics. Because one of the functions of the spleen is to keep bacteria out of the bloodstream. So if you don't have a spleen, you'll have a problem with bacteria taking up residence there. So we treat with prophylactic penicillin. All right. So that's sickle cell disease. Not a complete list of treatments, but your book doesn't go into very much detail about the treatments for sickle cell disease either. There's lots of new options. These kids and adults are followed by hematologists, which are medicine doctors that are specialized in blood illnesses. So there's always new ideas, new things being tried. All right, so that's sickle cell disease, a problem with one amino acid in the hemoglobin chains that causes red blood cells to change shape when exposed to areas of low oxygenation. Another hemoglobin problem behaves very differently, and that's the thalassemias. So technically there's two. There's an alpha thalassemia or a thalassemia alpha and a thalassemia beta. So hemoglobin, you might remember, is made up of 4 protein subunits, like that, and each one of them has an iron atom in the center of a heme molecule. So we have 2 alpha chains and 2 beta chains. So the alpha and beta here refers to which of the hemoglobin subunits is affected. So the problem here is not that hemoglobin is abnormal, it's that it can't get produced in adequate quantities. So thalassemia, there's thalassemia major and thalassemia minor. Thalassemia minor is the heterozygous condition. In other words, you have a good gene and an abnormal gene. What that means is every time the body goes to produce either alpha or beta using the abnormal gene, the hemoglobin doesn't ever complete. That subunit never gets finished. So it just doesn't get made. So in thalassemia major, they have a very severe anemia because essentially they can't make one of the parts of hemoglobin. If you can't make the beta chains, you can't make hemoglobin. If you can't make the alpha chains, you can't make hemoglobin. So thalassemia alpha is a problem with making the alpha chain. Thalassemia beta, problem with making the beta chain. Major is, are both, do you have a bad gene on both sides? Or heterozygous thalassemia minor, do you just have one bad gene? So essentially, in thalassemia major, these people often don't live very long because if you can't make hemoglobin, you can't survive. Thalassemia minor can be a very mild anemia because you can still make it, but not at normal rates. So your body struggles to make hemoglobin. Well, when you can't make one of the chains, the other has a tendency to build up. If the signals from the body are, we need more hemoglobin, the body's going to keep making alpha and betas. But if the betas don't get made, the need is never satisfied, so we get way too much alpha chains and not enough beta chains in thalassemia beta, for example. And that buildup of chains causes problems of its own, namely hemolysis, which makes the red blood cells pop open. So the thalassemias are pretty common. 100,000 children born each year. I think that's in America. I'm not sure. I don't think that's worldwide. But anyway, it's common enough where you will see people, particularly with thalassemia minor, because they live pretty much otherwise normal lives. So the signs and symptoms are the same as any anemia because they have an oxygen-carrying deficit. They don't have enough hemoglobin, so they can't carry enough oxygen. So they have high heart rates, easy fatigue, all the symptoms of relative oxygen deprivation. In addition, the bone marrow is hyperactive because it keeps trying to make more red blood cells with more hemoglobin, but it can't because the hemoglobin production essentially can't keep up. So the red blood cells that we find are microcytic and hypochromic, similar to what you'd see in iron deficiency. But the problem here is not iron, it's the protein itself. It's the hemoglobin that is not being made. So one of the things that can occur that's sort of strange in thalassemia is they can get iron toxicity, particularly if they're getting blood transfusions as part of their treatment. Whenever you give blood, you're giving iron, lots of it. So if those red blood cells don't survive for very long, that iron is going to have a tendency to build up in the body because it can't be incorporated into hemoglobin like it's supposed to, so it ends up sequestered in the liver and spleen, and that can cause problems all by itself. So treatment is with transfusion. Here we can attempt a cure, and that's with bone marrow transplant. We would only do that in the thalassemia major patient who is having significant clinical illness. Technically speaking, sickle cell disease could also be cured by bone marrow transplant, but usually the transplant pathway is more risky than not doing the transplant pathway in sickle cell disease. All right. Okay, so we have a couple of questions about anemias here. All right, so here comes the student number question. Did everybody get it? Okay. All right, enter your numbers, everybody. I don't have 11 yet. I have 9. Anybody not playing on the thing? There's 10. All right, last person. Let's see. I have.
It's me. I got it.
You got it?
Yeah, just
There we go. All right. Now we can do a real question. All right. End activity. Email report. Multiple choice. Okay, so which of the following is indicative of a hemolytic anemia? Which sickle cell disease is one example of a hemolytic anemia? Here, I'm going to start my timer over again. All right, that's everybody. All right, so the right answer here is D, jaundice. So increased total iron binding capacity, we're going to see that in iron deficiency. You know, essentially the proteins of the body are like reaching out for any little iron that they can get, so iron will bind much more rapidly. Increased heart rate we see in all anemias, regardless of type. And that's because one of the body's responses to a low oxygen condition is to make the heart beat faster to try to increase cardiac output. Hypovolemia, that's a plasma volume that's too low. We usually don't see that in anemias. You know, usually there's enough blood, it's just the right stuff isn't in it. You know, you see hypovolemia in trauma when there's been significant blood loss, or in shock where fluid is being put into some other space, not in anemias. But jaundice occurs when red blood cells are destroyed by something, you know, like sickle cell disease. That hemoglobin, the heme molecule that's part of it, gets broken down into bilirubin, and that bilirubin is excreted by the liver. If lots of red blood cells are breaking all the time, the liver can't keep up. So the bilirubin builds up in the bloodstream, and we see that clinically with yellow skin and yellow whites of the eyes, which is jaundice. All right, you can't even see that question. Okay, so we'll just go on. All right. So those are the anemias. Some of the most common blood disorders are those. But some others that we're going to look at this one, polycythemia, and then we're going to look at clotting disorders. So polycythemia is in some ways the opposite of an anemia. This is having too many red blood cells. And you might think, well, if normal red blood cells are fine, wouldn't more be better? Yes, to a point. At some point, if you have many more red blood cells than normal, the blood starts to get much more viscous and it has a hard time flowing through the body. So there's two types of polycythemia. There's primary and there's secondary. So in primary polycythemia, which is also called polycythemia vera, it's a primary disorder. In other words, it's not caused by something else. It's an inherent disorder all by itself. So this is the patient who doesn't have any other problems, who presents with a red blood cell count that is very, very high. It's typically thought of as a neoplastic disorder, in other words, a mild cancer. In this case, it's a fairly mild cancer. And the bone marrow is essentially producing too many red blood cells, and it's outside of control. Normally, red blood cell production is controlled by the kidney through the hormone erythropoietin, or EPO. But in the polycythemia vera patient, EPO levels are decreased. You know, the kidney is saying, okay, we have enough red blood cells, but the bone marrow isn't listening. It keeps producing more and more instead. Secondary polycythemia occurs as a result of something else. So, for example, the Tibetans that live very high in the mountains, and even we see a little bit of this in America at high altitude. The higher you live, the less oxygen there is in the air. So the less oxygen, the harder it is for the body to move oxygen around. So one of the reactions to that is you grow more red blood cells. More red blood cells means you can carry more oxygen for the amount of air or the amount of oxygen that's in the room. So anybody who lives at altitude will have a higher red blood cell count than people who live at sea level, because we see this phenomenon even in Denver. People have higher hematocrits in Denver because there's less oxygen in the air. So polycythemia doesn't become a problem until the blood flow starts to be affected by all those red blood cells, increasing the viscosity. You know, you can imagine, if you keep adding sugar, for example, to water, at some points it gets so thick that it's hard to move through things. Same thing happens with polycythemia and red blood cells. So the patient usually has a very reddish or bluish red skin tone because of all those red blood cells in their blood. The mucosa is also very red and kind of boggy because the blood vessels, the flow is very slow, so fluid has a tendency to leak out. A big liver and a big spleen are often present because those are blood organs. So the thicker the blood, the bigger the spleen or the bigger the liver. And the heart can get big when this has gone on for a long time because moving thicker blood is harder work. So the heart has to grow in size in order to accomplish that additional work. Diagnosis is easy. Simple CBC will tell us that a patient has polycythemia, because we don't just test for hematocrit and hemoglobin, we also count red blood cells in the modern CBC, so we can diagnose polycythemia very easily. For polycythemia vera, drugs or radiation suppress the bone marrow, trying to turn that red blood cell production down. And interestingly, this is one of the few diseases where drawing blood is actually a treatment, not just a way to test blood. So these patients sometimes will have red blood cells drawn, several times a month to keep their red blood cell count down. And they're otherwise normal red blood cells, so they can be given to the blood bank and all that. So phlebotomy can be used to remove those excess cells.
Do they give them their plasma back?
Not usually, because plasma grows back real fast, as long as they're drinking plenty of fluids. Yeah. All right, so polycythemia is sort of the opposite of anemia. Blood clotting disorders. Okay, these come up, very frequently. So they're worth, learning at least a little bit about the common ones. So thrombocytopenia, this is a platelet count that's too low. And it can be caused by a variety of different things. Both idiopathic, there's a disease called ITP, idiopathic thrombocytopenia purpura, where for whatever reason the bone marrow stops producing enough platelets. So the platelet count drops. And anytime the platelet count drops, bleeding problems are going to occur. Because the platelets are an important part of the hemostasis system. So infections can cause this through bone marrow suppression, certain autoimmune diseases like that ITP, chemotherapy and radiation. Any patient who's on cancer therapy will become thrombocytopenic at some point. And that's because cancer drugs attack the bone marrow more than other cells, because the bone marrow is all about cell division. And the cancer drugs are all against cell division. So one of the limiting factors in chemotherapy and radiation is bone marrow suppression and thrombocytopenia. So anything that drops your platelet count is going to cause a blood clotting disorder. Platelets can be defective. So in the case of uremia, which is can occur when the kidneys fail, for example, or ingestion of aspirin both makes platelets not work right. So the platelets don't stick together in the presence of those things, and if they don't stick together, they can't form that platelet plug that is the second part of the clotting cascade. So you'll have a clotting disorder there. Vitamin K deficiency, this can either be because of a problem in the liver or a problem in vitamin K intake. Now, usually we don't need much vitamin K in our diets because the bacteria that live in our small intestine actually produce it for us. So the only time vitamin K really comes up is in a patient with a very extreme or strange diet, or a patient who's not eating, not using their GI tract. So like the patient on total parenteral nutrition, for example, and in the very, very young. When babies are born, their GI tracts are sterile because they've never had any exposure to bacteria. So it takes about 6 weeks to 4 months for the babies to develop enough gut bacteria to produce vitamin K. In this country, before babies go home from the hospital, they all get a shot of vitamin K to offset this effect because there used to be a disease of clotting disorders in the baby, but we've done away with that with vitamin K injection. The liver creates the clotting factors, so anything that affects the liver in a negative way can affect the clotting system. You know, so the person in advanced liver failure is going to have clotting disorders. There are a number of inherited defects. We're going to talk about hemophilia in a minute, but von Willebrand's is another one you'll hear about because it's very, very common. And von Willebrand's makes platelets not function exactly right, so it's a mild clotting disorder. Certain viruses can result in blood clotting or blood clotting disorders where the blood doesn't clot. Ebola is a particularly nasty one that causes people to literally bleed out from all of their different parts. And then sometimes clotting disorders are our own fault. We have patients on anticoagulants, you know, because we're trying to prevent blood clots that can lead to a stroke or a heart attack, but those medications affect blood clots everywhere. So anybody who's on warfarin or heparin will have a tendency to bleed and not stop bleeding as quickly as somebody who is not on those medications. There are some foods and herbal compounds that behave just like warfarin or heparin too. So some of the, like, it's not really the nutritional supplements that get you, it's the herbal remedies. When you take a medication history from your patients, you want to include anything they're taking, not just prescription medicines, because there are some of those that behave like warfarin in the body. So one of the common signs of clotting disorders is this strange rash called petechiae. You'll see there's a bunch of little red dots. Now, the way to tell it's petechiae and not something else is most rashes, if you push on it with your finger, it'll blanch. In other words, the redness will go away and it'll turn white because, you know, when you push on it, you're pushing the blood out of that rash so it becomes white. In petechiae, they don't blanch, and the reason for that is these are not dilated blood vessels. These are little tiny blood clots underneath the skin that we're seeing, little tiny micro bleeds, essentially. So they don't blanch because when you push on them, the blood that has already leaked out of the vessels doesn't have anywhere to go. So petechiae are a common symptom of any platelet disorder or blood clotting disorder. It's particularly associated with platelets, though. If you have a board question with a petechiae rash, you're going to be concerned about thrombocytes or platelets. All right. So hemophilia A is the classic genetic blood clotting disorder. All of the hemophilias share something in common, and that is it's a deficiency in one of the blood clotting factors. You know, there are 12 or 13, depending on who you ask, blood clotting factors. So, and they all have to be there for the system to work. You know, it's not like if you have 11 out of the 12, you know, you get 95% clotting. It doesn't work like that. If you don't have all 12, you don't get any clotting. And that's because they all bounce off each other. It's sort of a cascade reaction. So in hemophilia A, which is the classic one, it's a factor VIII deficiency. So here's our clotting cascade. There's the intrinsic pathway and extrinsic pathway. Here's factor VIII. So in hemophilia A, they don't have that, which means this pathway never results in a clot being formed. Hemophilia B, which is the next most common, affects factor IX, which is one step above factor VIII in the system here. And then hemophilia C is factor XI, which is higher up in the chain. All of these affect the intrinsic pathway, but it's the intrinsic pathway that is in some ways most important in keeping blood in the vessels when there has not been an injury. If there's a cut or a trauma, it's activated from this side through the extrinsic pathway. But if you have a problem with any of these clotting factors, you don't turn prothrombin into thrombin, which means you can't turn fibrinogen into fibrin, and it's fibrin that makes blood clots. So if you can't do these steps, you can't make a blood clot. So the hemophilias are all genetic disorders. Hemophilia A is the different one because it's X-linked, which means that boys are much more, there are many more boys with hemophilia A than girls with hemophilia A. This is one of the genetic disorders that ran rampant in the European nobility in the Middle Ages, because their gene pool was so small and there was a lot of family trees that didn't branch, so to speak. There got to be more and more genetic disorders. So there are numerous princes and kings who had hemophilia A. So the signs and symptoms are hemorrhages. When they get an injury, they don't stop bleeding, and because they don't stop bleeding, it tends to be severe. A small wound doesn't bleed very much in a normal person, but a small wound in a hemophiliac will just bleed and bleed and bleed and bleed and bleed. So they can end up losing a significant amount of blood, even from a minor tissue damage, because there's no clotting. Another big problem is spontaneous hemarthroses. Joints undergo forces and pressures all the time. Your knee carries your body weight around as you walk all day. Well, all those forces sometimes rupture small blood vessels. And in the hemophiliac, those blood vessels don't clot. So you end up with bleeding into the joints. Particularly in, like little boys are very rambunctious and they like to challenge themselves and all that. So in little kids, you often will see a joint that has been damaged, and of course the child didn't know that, and you get a hemarthrosis, or a blood-filled joint, which causes a lot of pain and can cause permanent damage to the joint too if it's not treated relatively quickly. Diagnostic testing. For all of these clotting disorders, very common tests are the bleeding time and the PTT, which are the prothrombin time, and there's the prothrombin time, and I don't forget what the PTT one is. But basically, these are just tests to see how quickly you clot. And if you don't clot, then that's suggestive of hemophilia A. More often, we see the PTT as we follow our own. We've given them a clotting, an anti-clotting agent like warfarin or heparin, and we follow the PTT to make sure that it's not getting too much, so that they'll still clot if they need to. Treatment. Some patients respond to DDAVP, which helps the liver to produce more clotting factor. But most patients need factor infusions. So basically what they do is they give you the factor that you're deficient in. Now, you don't need to get them on you have to get them on a regular basis. But as long as you don't have any significant trauma or injury, you don't have to get factor infusions very often. However, if there's going to be surgery, anticipated trauma, or if there's been some trauma, you've got an 8-year-old little boy who has hemophilia and, he fell while playing baseball. one of the first things you'll do is give them a factor infusion to stop any bleeding that might be there. Now, it used to be that hemophilia was a huge risk factor for HIV, and the reason for that is it used to be we had to get the factors from other people's blood. So these people were not only exposed to the blood, they were exposed to the blood of many, many donors. Because in order to get enough factor to give them, you had to take blood from 500 people, let's say, and take the factor out of each one of those. So they had a huge exposure to blood-borne pathogens. Today, we can make these factors using recombinant DNA technology. So there's no longer a blood-borne pathogen risk to the hemophiliacs. So there are getting to be fewer and fewer hemophiliacs with HIV because the ones that do are dying off, and new ones are, the new generations are not getting it through the blood supply anymore. All right, so clotting disorders. You'll notice I'm skipping disseminated intravascular coagulation because we talked about it before. We talked about it when we talked about infection and complications of pregnancy. So in the interest of time, we're going to skip that one. All right, and the last group are the cancers, the blood cancers. So probably the most common is leukemia. This is just a cancer of the bone marrow that is causing the bone marrow to produce way too many white blood cells and white blood cells that are not normal or functional and are not under any kind of control. So basically, the blood is being filled up with white blood cells that don't have any use or any purpose. So we divide the leukemias into acute and chronic. So in the acute leukemia, the onset is very fast and abrupt. And typically, the cells that are produced by the bone marrow are very immature. In other words, they barely even look like white blood cells. They barely look like cells at all. They're deformed, they're strange, they don't do anything. They just take up space. So those are called blast cells. In the chronic leukemias, it's a slow onset, mild signs and symptoms, that eventually progress to an actual disease state. In adults, the chronic leukemias usually have a better prognosis. In kids, the acute leukemias usually have a better prognosis. So there's a big difference in leukemias in kids and adults. So, when you're studying for your boards, you have to keep that in mind. Leukemia is very different in the grown-up than it is in the pediatric population. All right. And the chronic leukemias, the cells are usually much more mature and partially functional. So they are doing something, unlike the blast cells that don't do anything, but they're not doing it as well, and there's way too many of them. All right. So acute and chronic, that's the first classification. The second classification is based on what type of cell is involved. So lymphocytic leukemias, it's the lymphocytes that are producing out of control. The myelogenous leukemias, it's all the other white blood cells, so the granulocytes, your neutrophils, basophils, eosinophils, they are instead producing too many. So chronic leukemia, more common in older people, but the prognosis is better. Acute leukemia is more common in children, and their prognosis is better. If you flip them, if you give a chronic leukemia to a child, the prognosis is worse. If you give an acute leukemia to an adult, the prognosis is worse. So ALL, which is acute lymphocytic leukemia, is the most common childhood cancer. So anybody who's working in the pediatric population, you will encounter patients with ALL or patients who have had ALL. We do not know what causes it. There aren't even really risk factors described. So ALL is sort of an out-of-the-blue kind of cancer, which is in some ways one of the worst kinds because it escapes detection. People don't think to look for it, so it can have been present for weeks or months, and no one has noticed. Some of the leukemias have a particular chromosome abnormality. It's called the Philadelphia chromosome, and it increases the risk factor, or it increases the prevalence of chronic myelogenous leukemia. So the Philadelphia chromosome is related to CML. And your book goes into a lot of detail about the Philadelphia chromosome, but I think that that is at the level of a hematologist or an oncologist, not just us normal people working with a clinical population. So what does leukemia look like? Because the white blood cells that are being made don't work right, it means you're immune compromised. So you'll have multiple infections. Infections become hard to treat because the immune system isn't helping you. One of the common childhood presentations is like an ear infection that won't go away, because the immune system is not helping to clear that infection. Also, strange infections you could add in this list too. Things that don't normally cause disease, are showing up as an active infection in a patient. You're going to want to check a CBC to make sure that there's not a leukemia present. Oftentimes, leukemia goes along with thrombocytopenia. Platelets are too low. The reason for that is the bone marrow is so busy creating these non-functional white blood cells that it's not producing what it needs to be producing, which is platelets and red cells. So usually, as the white count goes up, the red count goes down and the platelet count goes down. So you get thrombocytopenia and anemia. Bone pain is very common. And again, it's because the bone marrow is expanding as it's trying to produce even more white blood cells. So you get bone pain in the bone marrow region. So that's like at the hips, in the iliac crest, sometimes in the sternum, in the long bones like the femur, any place where there's active bone marrow and there's going to be pressure there which causes pain. Weight loss and fatigue. This goes with all cancers. Cancer cells are greedy. They gobble up nutrients much faster than other cells do. So they tend to steal nutrients away from the rest of the body. So we get weight loss and fatigue. Fever, same thing, hypermetabolism. Lymph nodes, spleen, liver, often enlarged because there's small amounts of bone marrow cells in those places too. If the leukemic cells have gotten into the CNS, you might get central nervous system disturbances like seizure, loss of consciousness, or change in consciousness. Chronic leukemia is harder to spot. It's the same symptom set, but instead of occurring over weeks, it can occur over months or even years. So it's much harder to identify. All right. So this one is fairly easy to diagnose. We do CBCs or complete blood counts on patients all the time, and usually the CBC is diagnostic. It's never normal to have a white count of 100,000. So if you get that CBC back and there's some horrifically large number that you've never seen before, you call the hematologist or the oncologist because it's probably a new diagnosis leukemia. So this is a cancer that can be diagnosed in the emergency room sometimes, even by mistake. Because we've gotten our typical emergency room blood panel, and sure enough, they've got an out-of-whack CBC. So suddenly, your ER patient who came in for a cold, and you have to have the cancer talk with them. So it can be, sort of startling. The diagnosis is really confirmed by a bone marrow biopsy. We need to see that the bone marrow is in fact producing these cells and is producing them in an inappropriate way. Treatment. All chemotherapy. Because we have bone marrow in so many places in our body, it doesn't make sense to use radiation. So it's all chemical therapy to try to destroy the cells in the bone marrow that have become abnormal and are producing these abnormal white cells. Kids have a great prognosis for leukemia. Cure is very possible. AML and CML are more difficult to treat, but people can live for a long time, up to 10 years. Bone marrow transplant is being done more and more often, and it's done if chemo fails. You'd like to have the person keep their own bone marrow. It's easier that way. There's less long-term complications. But if the chemo is failing, essentially you kill all of the bone marrow, so you turn the chemo regimen way up. You destroy the patient's bone marrow, and then you put new bone marrow in to replace it. All right, so that's leukemias. Lymphomas are cancers of particularly the lymph organs, namely the lymph nodes. So there's two main types. There's Hodgkin's lymphoma, which is also called Hodgkin's disease, and then there is non-Hodgkin's lymphomas. So, and it's because there are sort of two patterns that lymphomas follow. Dr. Hodgkin defined one, and then so everything that is outside of that one, they just call non-Hodgkin's lymphomas. So Hodgkin's lymphomas are one of the few cancers that are relatively common in young people, like you all. So men and women aged 20 to 40, that's a very common time for Hodgkin's lymphoma. Anybody ever had a Hodgkin's workup? No? You see them. I have a couple of students who have in the past. And in men over 50. So why that too? I don't know. Hodgkin's lymphoma is one of those, if you have to get a cancer, it's not a bad one to get because the prognosis is excellent if it's caught early. If it's caught before it spreads, it is exceedingly curable. The Hodgkin's version starts with a single lymph node that gets enlarged. It's usually non-tender, so it's just big. It doesn't hurt. Eventually, that lymphoma will spread to other lymph nodes, but it does so in kind of an orderly way. The lymphatic system is arranged in sort of a line. First there's the lymph nodes at your elbow, then there's the lymph nodes in your axilla, then there's the lymph nodes up in your chest, and Hodgkin's follows that pattern up. So, it will move up through the lymphatic tree. And in its worst case, it can spread to the liver and spleen, but that's the advanced stages. So Hodgkin's lymphoma is T lymphocytes, because we're going to see that the non-Hodgkin's is B lymphocytes. So this is circle-worthy right here. Hodgkin's is T lymphocytes. And in the circulation, we have a lymphocyte count that's low. So it's not like a leukemia where the white blood cell count is high. In lymphoma, the white blood cell problem is in the lymph nodes, not in the blood. So we'll see that. There's a number of different staging systems, but they all involve the number and location of the lymph nodes involved and which side of the diaphragm they're on. Okay, so stage 1, this is a single enlarged lymph node. This is when most Hodgkin's lymphomas get picked up because somebody notices a mass in their neck or a mass in their groin, and they come in for medical attention. So stage 1 is just one. Stage 2 is more than one, but on the same side of the diaphragm, so either above or below. Stage 3, multiple lymph nodes, both sides of the diaphragm. This indicates spread outside of just the lymphatic system. And then stage 4 is where the liver and spleen are involved. So you want to catch it in stage 1 or 2, but even in stage 3 and 4, cure is still possible. All right. So like I said, for Hodgkin's, the signs and symptoms, usually it's one enlarged lymph node. Usually it's cervical, so it's in the neck. Large, painless, and non-tender. Let's see. General signs of cancer, again, weight loss, anemia, low-grade fever, fatigue. Pruritus, itchiness is common with Hodgkin's disease. And then recurrent infection. Just like a leukemia, the lymphocytes are part of the immune system. So if they're sick, if they're not working right, you're going to be more susceptible to infection. Treatment is with excision. They'll cut that big lymph node out, and either radiation and chemotherapy or both are used to stop any potential spread, and that is usually curative. So you had cancer, but then you are cured. So Hodgkin's, one of the rare cancers that can be cured outright.
What was the difference between stage 3 and 4?
Stage 3 and 4 is the involvement of the liver and spleen. Yeah, in stage 4, you've got those organs involved. So that's Hodgkin's. Non-Hodgkin's lymphoma is similar in some ways. The biggest difference is in how it spreads and which lymphocytes are involved. So in non-Hodgkin's lymphoma, it's B lymphocytes. Again, single large painless lymph node, same presentation as Hodgkin's. Signs, staging, and treatment are the same, but the difference, Hodgkin's lymphoma spreads in that orderly way. Non-Hodgkin's doesn't. It'll skip around. So you might have a lymph node in your neck, and you might have a lymph node in your groin, and you might have one at your ankle, and one at your elbow. So there isn't that orderly spread of the disease like there is in Hodgkin's lymphoma. All right, so Hodgkin's and non-Hodgkin's lymphomas affecting the lymph nodes primarily, but can affect the liver and spleen because they also have lymphoid tissue. All right, and I think I left another one out here about multiple, what is it? Something dysplasia. Myelodysplastic syndrome I'm leaving out too because it doesn't come up enough to spend time on it. Multiple myeloma. This one's a little weird and its name doesn't really match what it actually is. A multiple myeloma is a cancer, but the cell that's overgrowing here is a plasma cell. Now, a plasma cell, despite its name, does not actually make plasma. Plasma is the non-cellular part of the blood. Plasma cells produce antibodies. So they used to be B cells, and they were activated to produce antibodies. And in multiple myeloma, they produce way too much antibody. So basically, you end up with huge amounts of antibody being produced, far more than the body needs. Those malignant cells start to replace healthy bone marrow, so you're going to have symptoms of bone marrow suppression. They erode bone, so you can have lesions in the bone itself where basically the calcium has been absorbed and that part of the bone becomes soft and breakable. And this one is infamous for rampant spread. It can spread all throughout the body, infiltrating any organ. And that's because plasma cells, in the normal case, have free run of the body. They can live in all kinds of places. So this is a highly metastatic tumor, multiple myeloma. It's a nasty cancer. Onset is usually insidious, so there aren't many symptoms until the malignancy is just widespread and advanced. Frequent infections occur. Even though the plasma cells are producing all kinds of antibodies, they're not producing the antibodies you actually need. So you end up at increased risk of infection because of that, an immune deficiency. Pain from the bone involvement, pathologic fractures from the bone involvement again, anemia and bleeding because of bone marrow suppression, low red blood cells, low platelets. Kidney function. Antibodies produced in huge amounts clog up the kidney. So you get proteinuria as the glomerular membrane breaks down, and eventually multiple myeloma will lead to kidney failure. So treatment is via chemotherapy, but a pretty nasty prognosis. Mean survival is 3 years. People don't live very long with multiple myeloma. Pain is always a major issue because of the bone involvement, so they require pain management. Transfusion of red blood cells and platelets. Usually, by the time multiple myeloma is diagnosed, it's too late for a bone marrow transplant because these plasma cells are going to be in other organs by that time, so that really isn't used. All right, so a couple of cancer questions. So JB is a 12-year-old boy with ALL. So manifestations prior to treatment could include which of those things? All right, jump in there, last couple of people, or we're going to move on. All right, so manifestations, would you see anemia in ALL? Yes, because the bone marrow is too busy producing blast cells. Would you see leukocytosis? Yep, you're going to see just a bazillion lymphocytes on the CBC. Leukopenia? No, that's the opposite of a leukemia. Leukopenia is not enough white blood cells. You see that in the treatment of ALL as the bone marrow is suppressed, but initially you're going to see leukocytosis, lots of them. And then thrombocytopenia, platelets that are too low, yes, again, because the bone marrow is so busy making these cells that don't work that it's not making the cells that the body needs. All right, so same kid with ALL. As part of JV's treatment, he has to undergo chemotherapy. What is the most serious complication of that chemotherapy? All right, there's everybody. So all of these are potential complications of chemotherapy. So nausea and vomiting, chemo has a tendency to directly affect the vomiting center of the brain. So it's one of the reasons why vomiting and nausea is so common with chemotherapy is it's not stomach irritation, it's a direct chemical effect. Basically the body is saying, this stuff is trying to kill me, get rid of it. But of course, that's the point. The point is to kill cells that are dividing too rapidly. So it makes people sick. Anemia, chemotherapy causes anemia, but anemia is easy to fix. You know, we can give red blood cells all day long. So it's not a serious complication, even though it is one that's present. Alopecia, this is losing hair, and we all know that very often with chemotherapy or radiation, patients lose their hair. Again, that's because hair cells are rapidly dividing, and chemotherapy attacks any cell that's rapidly dividing. But it's immunosuppression, that's what's going to kill you. You know, what is going to end the life of a child who's undergoing treatment for ALL? An infection. So that's the thing you have to look for. And unlike red cells and platelets, white blood cell transfusions don't work. I mean, you can do it, but it doesn't help very much. You know, you need your own white blood cells. You can't really use somebody else's. So that's the rate-limiting step for chemotherapy. All right, which of the following groups of clinical findings describes the typical presentation of ALL? All right, jump in there. I'll ask a couple of people. All right, that's everybody. So typical presentation is going to be A. So pain in the long bones, and that's because the bone marrow is trying to expand to make even more broken cells. Infection, that's as the bone marrow is producing all these blast cells, it's not producing the normal white blood cells that fight off infection. Fever, that's from the infection. And then bruising, that's from the thrombocytopenia that results from the bone marrow suppression that results from the ALL, from the cells being produced, the broken ones. You could have C, but asymptomatic in ALL, no, that would be CLL, chronic lymphocytic leukemia. Acute lymphocytic leukemia presents with symptoms, so it's not going to be... and then D, this would be a good presentation for Hodgkin's lymphoma. And B would be a good one for multiple myeloma. All right, so that's the blood disorders. And we'll just begin the cardiovascular disorders, which is right here. Think. All right. So I'm going to attack this one a little bit differently. as we're going to get to the various disorders. We're going to talk about vessel disorders, we're going to talk about heart disorders, and then we're going to talk about hypertension next time. But we use the same testing for all the different cardiovascular problems. So I thought that we would just talk a little bit about how do we assess the cardiovascular system, because we're going to see these used then in our various diagnosis regimens later on. So most of these you're going to have heard about already. You know, the EKG, we all know what that is. It records the electrical activity of the heart, the conducting system. You know, so the P, the QRS, and the T. And essentially it shows us the pattern of depolarization and repolarization that triggers contraction of the atria and contraction and relaxation of the ventricle. One you might not have heard about is we can put what's called a Holter monitor on a patient and essentially record their EKG for days at a time. So if you have a heart problem that maybe isn't always present, but it's sporadic or it occurs with certain activities, the Holter monitor is a great diagnostic tool because you get days and days or hours and hours of EKG, so you can really pinpoint, what is the problem with the conduction system. So that's a Holter monitor. The modern ones are very cool. They're all digital, and they're like the size of a little iPod Nano. I mean, little tiny things, but they're all wired up to the chest. Very cool devices. Auscultation, well, that's the old one. We've been listening to people's hearts even before they invented the stethoscope. Doctors and nurses would put their ear right to the chest to listen. And you really can hear a lot of interesting things. You can hear problems with the valves. You can hear problems with what we call shunts, or blood that's flowing in an incorrect direction. So we get a lot of information from auscultation. Echocardiography uses an ultrasound to take real-time live pictures of the heart, and it has just revolutionized our understanding of the heart because now we can watch it move. We can watch, and with the echo, we can do things like measure the speed of blood flow in various areas and things like that. So it is kind of a gold standard test. If you want to know if somebody's heart is normal, the echo is, if it's normal, my gosh, the heart is normal. So echocardiography. A stress test is just an EKG that's done while a patient's doing exercise. So typically this is done, on a treadmill. They'll wire you up to the 12 lead, they'll hit record, and they'll have you do some mild to moderate exercise to see if there's any change to your EKG as a result of the exercise or a little oxygen deprivation. In old people, we do this with chemicals instead. We give them a medication that effectively does the same thing. Increases the workload of the heart, causes a little vasoconstriction, and it challenges their system to see if there's a problem that develops with exercise. Chest x-rays don't tell us a lot. I mean, they can give us a sense of the shape of the heart and whether it's too big or too small. But we can see some evidence in the lungs as to how well the heart is working. If there's a backup in the lungs, in other words, the lungs are less dark than they should be on x-ray, it suggests that maybe the left side of the heart isn't pumping as well as it should. And we'll talk about congestive heart failure next time. Some fancy tests, nuclear imaging. This is where we give patients basically a small amount of radioactive material that is absorbed by the heart, and we can see how well blood is getting to all the different parts of the heart, to the muscle tissue in the heart. And more cardiac catheterization is the absolute gold standard for assessing the heart. The echo is the gold standard for non-invasive testing, but if you really need to know, the cardiac cath, basically a catheter is put in at the groin into the femoral artery or femoral vein. You work up the catheter all the way up to the heart, and then you start taking live x-rays as you perform various maneuvers, like injecting a little bit of dye that shows up on x-ray. And it's used to diagnose coronary artery problems, valve problems. Cardiac catheterization tells us, like I said, much about the heart. Today, we can also do some things with that catheter. In other words, not just diagnose, but treat. We can do what's called an angioplasty. This is where a little balloon inflates on the side of that catheter, kind of like a Foley catheter that some of you may have seen. And by doing so, it basically opens an artery. It pushes an artery open with air pressure. And we can put what's called a stent in. A stent is like a tubular wire cage. And we can, we've done an angioplasty, so we've increased the size of an artery. We can then put this little metal cage in there to keep it that size, to sort of hold that artery open. These are ways of trying to prevent open heart surgery or bypass surgery. All right. So here's just an example of what you can do at the cath lab. This is an angiography. So here is looks like the left coronary artery right here. And you can see how, there's white here and there's white here, but there's no white here. These two things don't connect, so to speak. And that's because this would be the site of a big clot. So this artery is being starved for blood. These all look fine, so I don't see any others. So we would call that a filling defect, and it suggests that there's either an atheroma there from atherosclerosis, or there's a clot there from a blood clot that's traveled to that area. All right. Some other tests, Doppler studies. Using the techniques of ultrasound, we can measure how fast blood is flowing and how smoothly it's flowing. So we can use this to find a blood clot, let's say, not just in the heart, but even in the legs or in the lungs. We can use Doppler studies. There are some blood tests that we use, like serum triglycerides, cholesterol, electrolytes, hemoglobin, hematocrit, all kinds of good stuff. And we'll talk more about that when we get to myocardial infarction here in a little bit. And then the ABG. There's no other way to determine how well the body is carrying oxygen and carbon dioxide, or what the accurate pH is without an arterial blood gas. You can draw blood from a vein and send it for these tests, but it doesn't tell you anything because the blood in the vein has already had all the good stuff taken out of it. It's had the oxygen removed, acid has been added, so the ABG obviously has to be drawn from an artery, but it's the only way to get an accurate pH and PO2 in particular. All right, so those are the testing. Some common treatment measures across these different diseases. Diet and exercise. Every single one of the things that we're going to talk about in cardiovascular health, diet and exercise is part of the treatment and prevention algorithm. Because it turns out that regular exercise promotes heart health, in other words, and vessel health. The lack of exercise has a tendency to produce things like arteriosclerosis and atherosclerosis. A diet that is high in fat and cholesterol has a tendency to contribute to atherosclerosis, which is a primary cause for blood clots and narrowed blood vessels. And the more weight you carry, the more work your heart has to do. And that's because adipose tissue has a pretty vigorous blood supply. So for every additional pound of weight you carry, the heart is having to push blood through a whole bunch more blood vessels. So it stresses the heart and challenges the heart. We recommend that patients with heart problems stop smoking because smoking causes vasoconstriction, which contributes to coronary artery disease or starving the heart for blood supply and oxygen, usually when it needs it most, like in exercise. I'm trying to see what time it is. All right, we got just a few minutes. Drugs, there are just a ton of cardiovascular drugs. And I've said before, this is not a pharmacology class. So we're not going to go through all of these things. If you're on the nursing pathway, which some but not all of you are, you'll learn about these either in your clinical rotations or in your pharmacology course. It's good to have some kind of a filing system for cardiovascular drugs, in terms of because many of them are similar, but they kind of do the same thing. For example, enalapril is an ACE inhibitor, and there are lots of different ACE inhibitors. There are multiple diuretics. There are anticoagulants. So because there are so many and so many patients are on these cardiovascular medicines, it's good to have an organizing system for yourself anyway. We are going to talk a little about nitroglycerin. Nitroglycerin, which is the very same stuff that explodes if you drop it, but there's never enough on the patient to actually, make an explosion. That's just movie stuff. But it works to cause vasodilation. And one of the reasons we use it is it's very quickly absorbed by the body. It's a little tiny molecule. So you put it under a patient's tongue, it's absorbed into the bloodstream, and it causes arteries to dilate. So a person who's having a heart attack or a person who's having chest pain, their problem is that the artery is too small. So nitroglycerin makes that artery open, and then more blood flow can occur. All right. I've reworked some of these slides in here to try to compress the time and get through what is more important. It's the same information that's on the slides that are on Angel. It's just organized a little bit differently. So it's not like I'm adding anything. I'm just talking about it differently. So these two words are confusing because they sound very much alike. They are two different vessel diseases. They can coexist. In other words, a patient can have both, or you can have one or the other. So arteriosclerosis is also called hardening of the arteries. This is something that happens to all of us with age. The older we get, the more rigid our arterial system becomes. So the arteries, instead of being nice, soft, smooth muscle tubes, they start getting calcium in them, almost like a tube of bone. So in the very old patient, in your late 80s, 90s, and you feel their arteries, they might even feel kind of crackly or crunchy. That's the arteriosclerosis, calcium appearing in the walls of those arteries. It results in an overall reduction in arterial flow. This is one of the reasons why, like, the elderly get cold and have difficulty getting rid of excess heat, is because all of their arteries have become narrower. So this happens to all of us. It can also contribute to high blood pressure. You can imagine a tube of bone can't change its size as well as a tube of smooth muscle. So they start to lose vasomotion, or vasodilation, and vasoconstriction. So this is a major contributor to what we call peripheral vascular disease, which we're going to talk about at the end of next time. But the one that gets more attention is this one. Atherosclerosis is a particular vessel disease that results in what we call plaques or atheromas. An atheroma is a region of blood vessel where the wall has gotten what's called a plaque inside. So let me just draw a picture because I'm not making any sense. All right. So here's a blood vessel normally. An atheroma is a thing that looks like this. And in here is kind of this nasty garbage that we call a plaque. And most of what's in a plaque is cholesterol, triglycerides, and white blood cells. So they are inflammatory. It's the body is responding. And the way these atheromas get started, we think, jury's still out, not all the science is done, but what it seems like happens, lining all of the blood vessels here are endothelial cells. They're sort of the Teflon lining on the inside of blood vessels. When endothelial cells get damaged somehow, atheromas form in the patient who's at risk for atherosclerosis. So what causes endothelial cells to get damaged in the first place? High blood pressure does. More pressure means more forces on those endothelial cells in the vessels, so they end up getting damaged. Cigarette smoking damages the endothelial cells too, both from vasoconstriction and irritation. there are probably a lot of things that damage endothelial cells. But that's step one. The inflammation that results from this damage is what leads to the formation of that atheroma, which contains cholesterol, like I said. The atheroma reduces the size of the vessel, right? You know, this is way bigger than this, and that's because the atheroma is taking up a bunch of space. In addition, atheromas, because they're inflammatory, you know, the immune system is working here, blood tends to clot around these atheromas. So it's a source of blood clots that can break loose and travel further down. It's also a spot, if you had a blood clot coming this way, it's going to get stuck right here because that's the narrow spot. And once it gets stuck, you know, our blood clot here, it's going to stop blood from flowing to the rest of that. So like that would be an infarction where blood was no longer flowing past that. So this atherosclerosis is a disease that causes other diseases, namely coronary artery disease. That occurs when this vessel is a heart vessel, so it starves the heart for oxygen. Atherosclerosis causes PVD, or peripheral vascular disease. This is a lack of blood flow to anywhere else besides the heart, so hands and feet in particular, are very common. And it's a cause of cerebrovascular accident, or stroke, because these atheromas can appear in the brain arteries too. So same illness, different places, different names, but it all has the same underlying cause, which is the atheroma formation. So just to show you that in pictures, here's a semi-normal artery, and we've got some endothelial cell damage here from, let's say, hypertension. That triggers the formation of a plaque. The plaque triggers the formation of a thrombus and a narrowing. See how much narrower that is than that? And then eventually the atheroma can clog off the vessel, but more commonly a clot travels downstream, gets lodged in this narrow spot, and then blocks blood flow distal to that. So an embolus is something traveling in the bloodstream. A thrombus is something attached to the wall. A thrombus can become an embolus, though. So a blood clot attached to the wall can break off, form an embolus. This embolus goes down and then blocks or clogs a smaller artery. So that's a thromboembolic event. All right. So we'll stop there, and we'll pick up there next time. So tomorrow. So we'll move that down there and put that there.